time. Professor Nobuyuki Shimokawa from Japan, please connect. You can share your screen. And we have already some questions in our chat, and we'll just ask all the participants them later. Thank you very much.
Can you hear me? Can you see me?
Yes, we hear you. We hear you. Yes, you can start your presentation. Thank you.
Okay. Okay. My topic is a posterior surgical technique. This is a photo. I was a member of WS Spine Committee from 2013 to 2008. This is a memorial photo in Russia. In
Can you please make it whole page? We see.
Yes. Press, please. Yes, play the presentation.
What?
The slides are not moving. You will see only all the slides together.
All the slides together.
Please click the whole page button on the right bottom place. Whole page.
Bottom.
Full. You can select the button, full presentation button.
Good.
It's okay. You can see?
No.
No.
Yes,
now it's okay.
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 Yeah.
Okay. Hey. Surgical indication for cervical OPLL. There is no evidence to recommend preventative or surgery for asymptomatic or mild cases. A good indication is a progressive type, including a rapidly or slowly. A relative surgical indication type is a large OPLL type and combined canal stenosis. This is K-line, as you know. K-line plus is a good indication for laminoplasty. In 2020, this paper shows surgical decision-making for cervical OPLL. Anterior approach is a K-line minus OPLL, and K-line plus and large OPLL. Posterior approach, K-line plus OPLL, and small type OPLL, and multi-level combined pathology, more than 3 levels. This is my case, is a CSM case. Posterior decompression, and 3 years after, the kyphotic changes occurs, and the patient deteriorated. But point of the kyphotic change of after laminoplasty is a chronic compression of ventral region of spinal cord. It means a compression of the anterior or spinal arteries. So decreased blood supply is related to the denervations. Among spinal surgeons in the 2010s, attention began to be paid to T1 slope and post-laminoplasty kyphosis in CSM cases. Like this paper, more than 25-degree T1 slope. In this paper, more than 26.5 degrees. In this paper, more than 29 degree of T1 slope. And this paper has a strong correlation among the T1 slope and C27 SVA. And operative not only T1 slope, but also T1 slope minus cervical lordosis and cervical lordosis per T1 slope in CSM. This is T1 slope. This is a C27 angle. So cervical lordosis per T1 slope indicates the tilt. And in this area is a good coordination. And 2022 from Japan, about the cervical OPLL, the SVA was also focused. This is vertical line. This is C7 posterior or cranial point. And this distance A A indicates the CSVA. So this paper was a retrospective studies. Anterior decompressive fixation case is a 28. PDF means a posterior decompressive fixation and laminoplasty. All laminoplasty cases were belong to K-line plus cases. High SVA group and laminoplasty group shows the postoperatively kyphotic change. Again, high SVA and laminoplasty group shows the kyphotic change and related to the lower recovery rate. In these cases, shows all mixed type OPLL, large SVA, and elderly patient. This manuscript concluded these patients should be went not only posterior decompression, but also posterior fixations. In 2016, in these papers, PDF should be recommended for large SVA cases. Here's Sakai. In 2016, he proposed a K-line tilt. This line is a vertical line, and this is a K-line, and this angle named K-line tilt. In 2023, Sakai proposed the K-line tilt is a predictor of postoperative kyphotic change after laminoplasty for OPLL. Kyphotic change group shows the high K-line tilt and large SVA and large C7 slope and lower recovery rate. So the author concluded K-line tilt more than 20 degrees was a risk factor of postoperative kyphotic change after laminoplasty for K-line plus OPLL. In 2019, Dr. Bajiri reported the review about the OPLL progression after laminoplasty. More than 50% cases has the OPLL progression after laminoplasty. This is a Chiba paper. Chiba, as you know, is a student of Hirabayashi Keio University. They emphasize that cervical OPLL expands in the early period after laminoplasty. This indicates a strong relationship between motion stress and OPLL progressions. PDF. In 2016, from Japan, they calculate the volume of OPLL, compare the laminoplasty group and the PDF group. Result, left side is a PDF group. Right side is a laminoplasty only group. You can see the suppression effect of PDF, of progression of OPLL. This is my case. K-line minus and B-cut type OPLL. 68 years old man suffering from a progressive motor weakness. The patient had a not so bad whole spinal sagittal alignment. So the patient underwent the kyphotic posterior or decompressive fixation surgery using pedicle scope. I left the anterior or large space for future additional anterior approach to the OPLL. Fortunately, the patient improved 1 year after and 5 years after. CT scan showing the this is a big portion of the OPLL. 5 years after the CT scan shows the flattening of the surface of the OPLL. Like that. Division surgery for OPLL. In 2024, from Korea, in this case, big type mobile segment, the patient underwent just posterior decompression. But 2 years after initial operations, the patient deteriorated. That's why the patient underwent anterior decompression directories. In these papers, the authors divided second operation plus group and minus group. Plus group showed the range of motion, large range of motion of OPLL or level. So the authors emphasize mobile segment and big OPLL are risk factor. In 2007, this is my case, 42-year-old man suffering from progressive motor weakness. You can see a small OPLL and combined protruded disc hernia like this, C5-6 level. The patient underwent partial vertebrotomy and grafted bone and fixed cylindrical cage corner to corner, named Homma method. Just post-operative radiograph and MRI showing a good position of the under decompressions like this. During 2 years after operation, the patient good recovery, but the patient complained neck pain and neurologically shows the C5 palsy of the right side. At that time, dynamic X-ray, you can see the minor instability at C4-5 and subsidence change of the iliac bone grafting portions and non-unions. Right side VA spontaneously occluded. It may be due to arteriosclerotic change of the severe diabetes mellitus. So I selected the posterior cervical fixation using the pedicle screw right side of the occluded side, and the lateral mass screw is the left side, patent VA side, and the posterior decompression of the foraminotomy of C5 nerve root. After the operation, the patient's neck pain disappears, and C5 pulse improved. 5 years after, good bony infusion obtained, like this. Progression ratio of cervical OPLL. This is my case. During 70 years, cranial directions 1.2 millimeter per year. Caudal direction 0.3 millimeter per year. Thickness 0.3 meter per year. Don't forget, OPLL is a progressive disease. In conclusion, currently, when performing posterior decompression surgery for cervical OPLL, the pre-operative radiological evaluation should focus on SVA, mobile segment, and K-line tilt. After posterior surgery, attention should be paid to kyphotic change, OPLL progression, and mobile segment. Thank you for your attention.
Yeah, thank you. And ask my moderator to continue. Professor
Okay. Okay. Now we can start the discussion. If you have any question.
We'll have one more talk, I think, no?
Okay.
There is one more talk, Serdar.
One more talk, yes.
Dr. Mehdi Darmol.
Okay,
continuous.
we can continue with the new talk, Dr. Mehdi Darmani, and then we can start the discussion after the all talks.
Okay, I will share my screen.
Okay.
Hello, thank you very much, Mehmet, for inviting me on this very important symposium. And I think the previous speaker, they have given a tremendous amount of knowledge and insight into the OPLL and the related issues. My question is with Oscar, do you have any dural tear or dural damage when you go for anterior side? You just remove the OPLL. OPLL is very densely adherent to the dural, and or you just thin it out and let it float off from the sac.
Please, you can activate the.
Thank you for the question, Tariq. I do not advise to remove the OPLL. I think what I do is the anterior floating technique, where with the drill, with microscope, you just thin as much as you can, and then you release on the sides, and then you see the expansion of the dura.
Yes.
I find the Zen technique very elegant, very difficult, but I'm afraid of doing it when you pull everything on a block and you don't see what you are pulling. You don't have a direct control of the situation.
And now
I'm much more confident in my technique with the anterior floating technique, which is, if you are a trained surgeon using a drill, you can do a very good job of decompression without risking CSF leak.
Okay, now we can continue the next talk, and then we can have questions from the participants. Please share your screen, Doctor.
Okay, thank you.
Okay.
We'll carry on discussion later on. Thank you.
Thank you.
Okay.